Lakshmi, and thank you, Brijmana. Okay, I think Anupama gave an excellent talk, and I hope that the video will be again shown because it's very difficult to make videos for all these conditions. Okay, so coming to thromboprophylaxis in pregnancy, again is very important. As all of us we know that earlier we used to think that the embolism does not happen in our country. Why should we give? But that is not the scenario. I'm involved in maternal death review, and I know that there are so many cases where if the thromboprophylaxis has not been given and they develop complications like pulmonary embolism and causes mortality. So I think it is very, very important. All of us, we know the guidelines and to whom to give, when to give, and how much to give. So coming to thromboprophylaxis, let us look at the rationale, whom to give, risk assessment, when to initiate, agents used, when to interrupt, how long to continue, and obstetric thromboprophylaxis, risk assessment, and management. So the rationale, if we see, we know that now there is a decreasing trend. I think today's maternal mortality, if I have to say for India, is 88, but that is overall. Still, I think some of the states are yet to achieve, and one of the cause is embolism. So the rationale is if we look at the direct causes of death, thrombosis and thromboembolism is only 1 per 1 lakh maternities. Antepartum hemorrhage and postpartum hemorrhage is 0.55. In them, the thromboprophylaxis. Amniotic fluid embolism is 0.42. Genital tract sepsis 0.29. Early pregnancy ectopic 0.25. Preeclampsia, eclampsia 0.25, and anesthesia 0.35. So, this was the surveillance of the maternal deaths in UK, and lessons were learned from this confidential inquiry relating to the causes of death, where they found that embolism was a cause in these patients. So, maternal mortality at a referral central, again, there is a study from Andhra. So, in this cross-sectional hospital-based study at a tertiary care center, it was found that 43 maternal deaths occurred and the live birth rate was 42,456. In 2011, the MMR was 96.37 and 2015 it was 99. So hemorrhage was the leading cause of death, followed by thromboembolism, which was the indirect cause of maternal mortality and anemia. So even though we think, like Andhra, if they have done the study, that means they have properly done the maternal death review, because sometimes what happens, mysterious deaths, very difficult to diagnose because we don't get the postmortem done. We just say that the patient has refused and we just leave them. But now at least we have done the recommendations in Karnataka to see to it that if the woman has died of a cause which is not known, the autopsy or the perimortem is must. So the changing patient's profile nowadays, what we see is they're older, elderly primaries, they are obese or overweight, smoking, previous cesarean section. IVF pregnancies are on the rise. And due to that, even multiple pregnancies are on the rise, and the medical disorders like HDP, diabetes, all these. So now whom to give? So I think when we are trying to do the scoring, it is very important that we have to look at the scoring system, and I think which is given by RCOG. So pre-existing risk factors are very important. If there is a previous history of VTE, except a single event related to major surgery, then the score is 4, very high score. Previous VTE provoked by major surgery 3, known high risk of thrombophilia 3, medical comorbidities like cancer, heart failure, active systemic lupus erythematosus, inflammatory polyarthropathy, or inflammatory bowel disease, nephrotic syndrome, type 1 diabetes mellitus with nephropathy, sickle cell disease, current IV drug user, it is 3. If family history of unprovoked or estrogen related VT, that means you should ask for family history also. Known low risk of thrombophilia, no VT, again 1. Age more than 35, 1. Obesity, 1 or 2. Parity more than 3, 1. Smoker, 1. And gross varicose veins, which is a very common feature. Coming to the obstetric risk factors, preeclampsia in current pregnancy, 1. ART, IVF, antenatally only, 1. Multiple pregnancy, 1. Caesarean section in labor, it is increased to 2. Elective cesarean section 1, mid cavity or rotational operative delivery 1. Prolonged labor more than 24 hours, PPH more than 1 liter, preterm birth less than 37 weeks in current pregnancy, and stillbirth in current pregnancy. That means what? There are so many conditions. I don't think we are concentrating so much on these conditions. For example, if you take prolonged labor or if you take a forceps surventis delivery, do we think that this patient needs thromboprophylaxis? Then there are some transient risk factors. Any surgical procedure in pregnancy or puerperium except immediate repair of perineum, for example, appendicectomy, postpartum sterilization, etc. It is 3. Hyperemesis is also because the patient will have a dehydration. Okay, these hyperemesis patients are always dehydrated. OHSS in first trimester only 4, very high. Current systemic infection 1. If the patient is immobile, there is dehydration 1. So coming to risk assessment, it should be done early pregnancy, pre-pregnancy, on admission to hospital for any reason, intrapartum or immediate postpartum. Now, when to initiate? Timing of initiation of thromboprophylaxis, if the risk score is 4 or more, throughout pregnancy, we have to give her until 6 weeks postpartum. 3 risk factors after 28 weeks of pregnancy, we have to start continue till 6, and 2 risk factors postpartum at least for 10 days. So any previous VTE except a single event related to surgery as early as possible, usually after pregnancy is confirmed. Now, which agents are used? Yes, heparins. Either unfractionated or low molecular weight, which does not cross the placenta and cause fetal anticoagulation. Safe in breastfeeding. LMWH is the agent of choice. UFH, preferred peripartum when increased risk of hemorrhage is there or where regional may be required. But sometimes what happens if you have a patient suppose she is APLA positive and she already had a history of VTE and she is on low molecular weight heparin. So what happens is, suppose if you want to deliver her or you want to do a cesarean section, it is very risky to stop her because she will be not on a prophylactic but on a therapeutic dose. In those cases, you can stop heparin and switch over to UFH. Because in case emergency she goes into labor, we can stop it even 6 hours prior. So that is the thing which you have to do with UFH. Now, if you compare UFS is cheaper, shorter half-life, it is given subcutaneous or IV and can be reversed rapidly. But it causes HIT, bone loss, needs monitoring baseline platelet count after 2 to 3 days and weekly 2 weeks and then monthly. Whereas with LMWH, we do not see that much. Here it can cause thrombocytopenia. So it is preferred in patients with severe renal insufficiency is advantage. LMWH is effective, easy to administer, subcut, has more predictable response and do not require routine monitoring. Now, heparin anticoagulation dosing, prophylactic dose of anticoagulation, it reduces the risk of thromboembolism and minimizes the risk of bleeding. Intermediate, adjustment of prophylactic dose with weight gain in pregnancy. So, early pregnancy, you must have decided less, but she is gaining weight, then more. Therapeutic dosage are reserved for the treatment of thromboembolic diseases. Now, what are the suggested doses of LMWH for antenatal and postnatal? See, if the patient is very thin, less than 50 kg, you can just do with 20 mg daily. But if you are giving LMWH, if dalteparin is 2,500 units, tinzaparin is 3,500 units daily. As soon as you find between 50 to 90, the dose of LMWH will be 40. More than 90 to 130, it is 60. Still heavier than that, 80. And if she is more than 170, then it is calculated as 0.6 milligram per kg body weight. Now, dalteparin and tinzaparin are not in regulars with us. At least we do only this. Now, high prophylactic dose for women weighing more than between 50 to 90 kg, that is 40 mg, 12th hourly you may have to give these patients. Dosage of unfractionated heparin 5000 IU subcutaneously 12th hourly throughout pregnancy. Injection heparin subcutaneously 12th hourly with increase in dose as pregnancy progresses. First trimester it is 7,500, 7,000 to 7,500 to 10,000 in second and more than 10,000 in third. No monitoring usually, but a APTT done if any concerns about bleeding or thrombosis. Contraindications or cautions. Unknown bleeding disorder like hemophilia, von Willebrand disease, or acquired coagulopathy, active antenatal or postpartum bleeding, women considered at high increased risk of major hemorrhage like placenta previa, thrombocytopenia where the platelet count is low, acute stroke in previous 4 weeks, could be hemorrhagic or ischemic, severe renal disease, okay, glomerular filtration rate less than 30 ml per minute, severe liver disease, prothrombin time above normal range or known varices, and uncontrolled hypertension where the blood pressure is more than 200 millimeters of systolic or more than 120 millimeters of mercury of diastole. So these are the contraindications for low molecular weight. Now, warfarin, we know many patients have undergone the cardiac surgery. They will have a wall replacement. They will be on warfarin. It is avoided as it crosses placenta. Teratogen cause fetal embryopathy. Fetal anticoagulation can result in intracranial hemorrhage, considered only for with high risk of thrombosis with mechanical valve. Safe in breastfeeding. And anti-embolism stocking. See, suppose if we are going to ambulate the patient early, there is no need to start sometime, you can just give her the stockings also. Now, during labor and delivery, what are the do's and don'ts? Thromboprophylaxis interrupted if woman has any vaginal bleeding or labor pains. If elective LSS is planned, regional technique avoided for at least 12 hours after prophylactic dose of LMWH and 24 hours of therapeutic dose, 6 hours and 12 hours with AFH. I told you with AFH lesser time because the patient can bleed. Okay, so you have to, if it is a planned surgery, planned delivery, you will have to stop it 24 hours prior. If epidural catheter is to be removed, not to be removed within 12 hours of recent injection. Now, when to initiate postnatally? Vaginal delivery after 6 to 12 hours if there is an indication. If no PPH and no epidural. Caesarean section after 12 to 24 hours. Resumption in patient receiving antenatal thromboprophylaxis can be earlier, 4 to 6 hours after vaginal delivery and 6 to 12 hours after CS in the absence of significant bleeding. Now, for how long should thromboprophylaxis should be continued? High risk women 6 weeks, intermediate risk women 10 days, additional persistent risk factor you have to extend up to 6 weeks or till the factor persists. So this is the chart. Antenatal assessment and management to be assessed at booking or repeated if admitted. Any previous VTA except a single event related, I told already, comes under category like score will be 4. So high risk case requires antenatal prophylaxis and refer to trust nominated thrombosis in pregnancy expert. It is better. Hospital admission, single previous VTE related, high risk thrombophilia, no VTE. Medical comorbidities, which we already discussed, will have a 3 score, like cancer, heart failure, active SLE, IBD, or inflammatory polyarthropathy, nephrotic syndrome, type 1 diabetes with nephropathy, sickle cell disease, current IVD. So any surgical procedure, for example, appendectomy or OHSS. Now coming to obesity, BMI more than 35, more than 30, age 35, parity 3, okay, and gross varicose veins, current preeclampsia, immobility, all these patients, family history of unprovoked or estrogen-provoked VT in first degree relative, low risk thrombophilia, multiple pregnancy, IVF and ART. And transient risk factor is the only low risk, that is dehydration, hyperemesis, current systemic infection and long distance travel. These are all the transient risk factors. Now, what happens, you get patients, who just want to go for a abroad trip before pregnancy. Now, all new trends have started. And it becomes so risky for us, for these patients, whether to advise them LMWH, they will be already obese, more than 35. So it becomes really difficult, but you have to explain them the risk. Coming to the postnatal, again, any previous VT, anyone requiring antenatal LMWH, high risk thrombophilia, low risk thrombophilia, she will be a high risk. So she will require at least 6 weeks. All intermediate risks is cesarean section in labor, BMI more than 40, readmission or prolonged admission of more than 3 to 5 days in the puerperium, any surgical procedure in the puerperium except immediate repair of perineum, and medical comorbidities, which we already discussed. So that comes under intermediate. So you will have to give postnatal prophylaxis for 10 days. Okay. And if there are any factors which are persisting, then or more than 3 risk factors, consider extending thromboprophylaxis for a longer time. Now, here also what happens, I would like to stress upon this here, because in private practice, now particularly in corporate hospitals, what is happening is the patient is discharged just after 48 hours. And we have seen mortalities happening. And the patient, because it is all monetary, they have a package. So we had to literally get back to them and tell them that thromboprophylaxis is not given and patient gets admitted at 6 a.m., gets surgery done at 8 a.m. That day she stays. The next day she stays, and third day she's out. If they don't go, they have to pay extra. So the patients don't want to pay because they have already paid. I mean, these are the certain factors which we have observed and which are really causing more problem. All the more they'll be obese, they'll be post-cesarean, they will not move, they will not be ambulatory. So these are the risk factors again where you will have to take. If there are 2 or more risk factors in this category, that will become an intermediate risk, like morbidity, obesity, age more than 35, smoker, elective cesarean section, family history of VTE, low risk of thrombophilia, gross varicose veins, current systemic infection, immobile patient, current preeclampsia, multiple pregnancy, even preterm delivery, stillbirth in this pregnancy, operative delivery, prolonged labor of more than 24 hours, and PPH of more than 1. So these are the patients. If there are 2 or more risks, then it becomes intermediate again. So you will have to give them heparin for 10 days. Lower risk, suppose if there is a low risk, then early mobilization and avoidance of dehydration, which is very important. I already stressed upon that. So actually, we have put up this chart in our postnatal ward also, because they get confused how much to give, to whom to give. So it is better they do the gradation and they know that the patient is falling in high risk, intermediate, or low risk, and accordingly the heparin is given. So to summarize, all women should undergo risk assessment for venous thromboembolism in early pregnancy and pre-pregnancy, reassessment on any antenatal admission during delivery and postpartum period. Both can be used for thromboprophylaxis. LMWH is effective and easy to administer in dose of 40 milligrams subcut once a day and does not require any monitoring. And we have diagnosed so many APLAs now. Okay, I remember my own experience where the patient had developed embolism and I went for the rounds. So what I did anyway, OT was on the same floor. I literally pushed her on a trolley. Anesthetist was there and UFHW only was available there. And I gave her stat dose of 5,000 international units. Okay. Now all women should undergo risk assessment for venous thromboembolism in early pregnancy. I think we discussed this. All women with 4 or more current risk factors should be offered prophylactic LMWH throughout antenatal and 6 weeks postnatal. Any woman with 3 current risk factors should be offered prophylactic LMWH from 20 weeks gestation and 6 weeks postnatal. Any woman with 2 current risk factors should be offered prophylactic LMWH for at least 8 days. So this we are talking about prophylaxis, which is happening even antenatally also. Short-term thromboprophylaxis should be considered for pregnant women admitted with hyperemesis gravidarum or ovarian hyperstimulation. Risk of VTE should be discussed with all women. At risk, necessary precautions should be observed during delivery to avoid complication. And thromboprophylaxis can be started after 6 to 12 hours after vaginal delivery, 12 to 24 hours after cesarean section.